as we know that physician engagement and incentivization model is the holy grail of any healthcare ecosystem, and it's been evolving over a period of time, has had success and failures in different parts of the world, in different formats of healthcare. And it certainly is one of the most critical as well as controversial topic when it comes to emerging markets, especially like an economy like India, where the need gap is very, very high. In the Western market, again, it is a matter of debate, and we have now witnessed the most evolved market trying to change the tact of how engagements are worked upon. So in a market like US, which is a strong payer market, you have one large stakeholder, which is insurance, which is driving the shape and form of the market, wanting to change the way physician engagements are being done. And some of the most successful healthcare systems, if I can talk about Cleveland Clinic, they are basically changing the face of physician engagement. So what we saw in the previous few decades in the Western market, where the model had gone to, from a fixed pay to a fee-for-service kind of a model, and people have seen the negative side of that. So now institutions like Cleveland Clinic, Johns Hopkins are moving towards moving back on the fixed pay model. There are obviously pros and cons, and you cannot use the same brush for all the markets. In the context of an emerging market like India, where the demand far exceeds the supply, it's a very complicated aspect. So just to throw in some data point, and just to throw in the light of how complicated the market is, all of us are aware of some of the data points that we have as far as the mean physician to patient or population ratio is concerned. India ranks amongst the lower quartile of the global average number. So we have about 6 or 7 physicians to 10,000 population, and within that it gets all the more complicated when you look at the micro markets. So you have a southern market where the physician ratio is 40 to 10,000, which is probably one of the highest in the world. And then you have a market which is more in the eastern northern side, where the physician to population ratio goes down by 1/10 of what you have in southern India. So it basically complicates when you look at micro markets, and that's the way you should look at. Mean there's no way to look at any market. It complicates. It gets all the more complicated. And then when you see the divide between the urban market and the rural market, the 70-30 ratio, which is 30% resources catering to 70% of the population, it again becomes all the more complicated. So I guess with this backdrop, what I would like to touch upon in this session is, first of all, should there be an incentivization model, especially for a sector as sensitive as healthcare, which touches human lives and where the conflict quotient is very, very high. And if we do need to have, then what are the forms that we should look at, both in the context of a private market as well as in the context of a public market. So that's the backdrop, and that's the macro question that we would like to address. And I have 2 eminent panelists with me. So I'll go with the most controversial question, and that I'll pose it to both the panelists, starting with Dr. Sanjeev. Should there be an incentivization model for physicians?
Thank you very much. It is definitely controversial, but I come from a very different background. We are a not-for-profit private academic and research organization. And if your question is, it's a financial incentive, then I don't think we as an organization have that vision or an ethos at all. We have close to 840 physicians with us. All of them are on fixed salary with a group practicing. And there is, the incentive comes in the terms of giving them a vision of complete comprehensive development as a physician. So that means when they have to take time out, collect few data set, publish it, and that goes into their performance appraisal. So they have to do 2 national, 1 international publication per year. That means that similarly they will have to do research and they will have to write grants. The seed money would be provided by the institution, but they need to write grants, they need to do either basic science or trials. The incentive comes from the help which the institution gives to them. So there are biostatistics full department, there are clinical research department. The other non-financial incentives that there is huge help with respect to the academics which comes in, which helps them a lot. So it would not be just a person who keeps on doing angio and angioplasty. So he will be aided by a few other group of people who would be postgraduates, who will also have a cath lab technician and a perfusionist technician, because there is a huge set of academics. So there is a help which comes to him with respect to clinical support, and he gets some time out to do something which gives him or makes him more comprehensive physician. And that is why our attrition rate with doctors have been almost negligible, except for few when the new institutions come in. And I think we are able to sort of manage them and keep them within our loop, giving this vision that they need to provide healthcare and they need to be productive with more clinical outcomes rather than just looking at financial incentives.
Yeah, so before I move to Ankush, there's just one leading question. What I hear from you is that we should have incentive for doctors, and in your case what you're suggesting that these are all non-financial incentives in nature. But do you think doctors, and you have a whole lot of this doctor, the doctor said, who would be satisfied with the non-financial incentive model that an institution like yours has?
So they do, and that's why possibly they are sticking with us. So like we promote them, we have 25 international collaboration with various institutes. So we have space for them for taking sabbatical. So they would go to Cambridge, be at a consultant post, we do all the GMC registrations for them. And they'll be 2 years consultant, and consultants are very decently paid. So that's the sabbatical, that's a non-financial incentive, but we help them to take that sabbatical. But it is just not to earn, but to get the competency and skill sets and come back and develop a particular service. So it could be simultaneous pancreas kidney transplantation. It could be small bowel transplantation. So it's a non-financial incentive which comes in various reasons. It could be just taking sabbaticals, it could be a lot of help from academic side, it could be providing their career path and their family's engagement too. It's just not physicians' engagement. So we engage with the family and they're part of us. So that way I think they're still sticking with us, so possibly it works.
Ankush, your thoughts on this?
I work for non-profit organizations and I work for for-profit organizations, so I've seen both the worlds. And primarily the objective which with a physician goes to a private sector and opts out of something as wonderful as what Amrita Institute is doing are manifold. One of them is also financial in nature. So we cannot completely say that financial incentives are not required by doctors. They can be productivity linked. There may be a number of ways by which private organizations are doing incentivization of doctors who are working inside the organization. And there are very many objectives why that incentivization is being done. All of us who are practicing in private sector we have seen physician engagement models and compensation models. We all know that there is a minimum guarantee that is being offered to a doctor. And once he crosses the threshold of volume, then there is an incentive which is put into the compensation model. So in some cases it has minimum guarantee plus incentive, in some cases it has minimum guarantee or incentive, whichever is higher. When you calculate the compensation per procedure basis and try to find out that what has been the contribution of that particular physician or clinician in the department, you try to do that. So all this non-financial type of things which are being done by good institutions like Amrita are in any case also part of the corporate organizations. So one of the most important aspects of non-financial incentive directly to a doctor is the tech play. Most of us, what we grapple with is that our senior consultants, if you want them to engage in the organization, then they all like tech toys, So you need to keep investing in those tech toys, and you start bringing those tech toys to their table, and you really don't know that the ROI would come on the tech toys, So those are some of the important things that, apart from academics, research, I can tell you a number of corporate organizations where there are DMB programs, there are research programs, there are sponsorships for conferences, and there are pools where doctors are being sent outside for clinical training. But apart from that, unfortunately in our country, when a doctor earns, there are a lot of taboo to it. Doctor earns. We are all worried about doctor earns. Anybody else earns, it is fine, but when a doctor earns, there is a lot of problem to it in our country. So my take on it is that most of the corporate organizations, they do have incentive model. It's a matter of debate that how that incentive model is being crafted and what are the elements of those incentive models. But that is how the engagement takes place.
Thanks for that. So Ankush, again a leading question. So obviously, since you come from a profit organization, the incentivization has to be there. But if you were given a choice, see, there is a market-driven model, because again, all of us are fighting for the scarce resource, which is called doctors. And in most situations, we see that we're driven by the market model. And in most cases, it's regional in nature. If you were given a choice to craft an incentivization model that works for a physician and plays into both the financial and the non-financial aspect, and also benefits the organization, what would that be?
The most important thing is, in the previous session we heard that activity-based costing is missing out of the hospitals. There are very few hospitals. Dr. Desai is mentioning that in the hospital costing department, 13 people employed. When you work out the incentive model, the first thing is you need to understand what's the input cost. This is what is coming to you in terms of revenue. Now when the market is getting regulated, and it's getting regulated so thick and fast, we heard Mr. Alok saying that 60% of the population in India will come under Ayushman Bharat. Now when the prices are getting regulated, and you need to understand what your cost structure, until unless that input comes, it will be very difficult to find out what's the profitability of the department. You have to work at the macro level and really find out that what is the profitability. Now if you look at the profitability piece, that is difficult to calculate. If you look at the outcome piece, when we talk about the overall quality of service, and if you try to bring in that element into the incentive model, what a doctor controls is only the medical outcome. There are a lot of touch points which a patient experiences throughout the journey in a hospital to get treated and cured. Now the definition of quality from a medical outcome perspective is very difficult, because there are complications, cases have different clinical pathways, there are different ways of treating. Every physician has their own judgment based on their clinical practice and their academic training, and so on and so forth. So it will be also very, very difficult to really pinpoint that clinical outcomes eventually, to a large extent, can be made part of the competition model. So you can have your own historical data, and you have data coming from the medical books and so on and so forth to set benchmarks as to what should be the medical outcome and what it has gone. And I'm sure all the corporate hospitals have those type of committees and policies to review what's happening in their medical departments. So a benchmark can come from there, a benchmark can come from volumes, right? But again, if you're giving me a choice, I think that it's not a question of my choice. As you rightly said, it's the market dynamics. If the 60-70% of your work in the hospital is getting to get regulated through third-party payers, then you don't have the headroom to actually set the price. And when you don't have the headroom to set the price, you'll have to possibly accept and get into habit of regulated price mechanism. And the earnings arising out of it can be only shared with the consultants in their compensation model. So the day is not far that you will again come back, as you rightly said, what happened in US is highly regulated. The day is not far that you have fixed compensation models and people will have to live with it. The compensations, like in any other hospital, which is public sector hospital, you have pay scales based on seniority, you have grade structures from grade 1 to grade 7, so on and so forth. You will have to possibly live with that in the private sector also.
Thanks for that. Sanjeev, we come across situations and we hear a lot of murmurs in the market that institutions that are not paying the doctors well, there are other forms of incentivizations which we hear about, which are internal and external. So what's your take on it, of how you see the market evolving? Because now what we are seeing is that since more and more corporates are getting into this field, they want to keep a close watch on the profitability and they break out each of the cost drivers and want to see that profits are consolidated and retained with the corporates. But at the same time, we see large number of hospitals who are not successful in controlling the cost. It's because they tend to hire star doctors, and doctors have their own ways of working. So what is your experience and what would you suggest how to curb that kind of model?
So I would think that an institution, when they are building it up, like you said, market dynamics, and a lot of the scenario is driven by market dynamics. I think the doctor and the institution is left with a choice. So, including our institution, we have a choice. So, what is our vision and what would be our mission to get to that vision? So, when we started 20 years back, all our head of departments were at the age of 35, 38. And we interviewed them. It was because a lot of people wanted to join, but it was only select people who were interviewed. And they were allowed to build their own team. So right now, like if I give an example of gastrointestinal surgery, now this gentleman who had come from GB Pant and who came back to Kochi after doing his MCH, he was 36, he was head of department. He built his own team. And right now there are 15 people in his department, none of them have left. Now what did he do? So he also started, he went to an institution in Brigham's, and then he created a position there for a year, and he did not do it for his personal benefit. Every year he is sending his juniors to go to Brigham's and acquire specific skills and come back. So there is huge engagement within the department. So all of them would be extremely competent in skill and could be easily poached. But that is the kind of environment which the department head creates with support from the management. And that is where none of them have left. So I think the intent was that you invest on good people who are not looking on fast buck, but looking on their growth, looking at institutional growth and something which is much bigger. So can you strive to be part of Institute of Eminence rather than being a star doctor? This concept of star doctor is, it is for some more time, because I think they destroy the whole market right now. They do bring in immediate clientele and immediate money, but they disturb the whole cost structure. And I think that is destroying the Indian healthcare market, and I think something needs to be done to stabilize this cost factor of paying out the star doctors. So there are plenty of stars, and that is another etho within our institution that we mentor, there is a huge mentor and mentee relationship. So the star doctors may not train people because they just go on their volumes and they are building and they buzz on their volumes. But I think it would be important, can a cardiovascular thoracic surgeon create another cardiovascular thoracic surgeon so that the competency passes on. So I would really not buy the star doctor concept because I think it is the dynamics gets disturbed. But I think we should look at healthcare as healthcare, and maybe you make a business out of it. We do also we rob the Peter and pay the Paul, but it should be largely seen as healthcare in a context for the patient and not just making business of it.
So the point that you're making is that it's all about starting off with the right culture and choosing the right leader who will basically help percolate that culture, the leader that you spoke about. But how many institutes do you think, or companies do you think have that mindset, and if they have the mindset, would be successful in sustaining that? Obviously trying to start with the culture, and because the market forces are against them, the practice that Ankush mentioned, 70% of the market following a particular model, will be able to sustain that kind of a pressure for long enough to create the culture and then create a success story like what you have.
So we 6 years back we were looking at having another Amrita in Delhi and NCR, and we were also thinking that we are getting into a wrong area, and it is a very, very commercial market, and let's be in South because it's still ethical, it's still manageable, and we would be a South-based. I'm just quoting this example because for last 1 year I have been interviewing faculty for our new facility. And we are overwhelmed by the response of the physicians who are coming to us. We never thought people will come because we are not good payers, but we would bring up a physician so that he cherishes being with us and cherishes to do something which is extraordinary, outstanding. So some research work which I didn't comment when the other panel was going on. We have 5 engineering institutes, and we have research day quarterly where the doctor comes and he says his problem. If the engineering institutes can help, nanomedicine can help, biotechnology can help, and some of the things which is happening right now with nano and biotechnology are path-breaking. So that is the excitement which the physician should have rather than just looking at that buck. So to answer to your question, how many will adhere to it? We also thought that we are going into a wrong area, let's build in Chennai or somewhere else. But we are seeing doctors, and when we interview doctors, they are all fed up with targets. They are all telling us, we ask them, why do you want to come to us? Because we may not be good payers. So they say they are fed up of every month being told that this is your target, this is the volume which you need to achieve. And they are fed up, and that's what they would like to come down on salary too, but would like to join. And we are very happy that there are good people. It's not that the others are not good, but there are people, there are physicians who are not just looking at financials.
Yeah, Ankush, your take on this.
See, if you look at it, let me give an example of an investor who's putting 200 crores to build a 150-bed hospital. It's very interesting. We are saying 70% of the patients would come from regulated market. 10% would come from out-of-pocket insurance. Those people like us who are not below poverty line, our government says that if you are earning 8 lakh rupees per year, you are not garib actually, because you are not even economically backward. Economically backward reservation is being given to people who are below 8 lakh rupees. So people like us, we buy our insurances, and 10% of our patients come from insurance sector. So 60-70% would come from a variety of schemes which are getting amalgamated into one large scheme, and 10% would come from that. So you're left with only 20% patients who are out-of-pocket patients, right? And there's a lot of debate going on right now between exemplary care and reasonable care. Right? The definition of care is based on how much money you have in pocket. People still go to US, people still go to Singapore because they have money. For angioplasty, they still go to Singapore and they still go to America. We have seen celebrities going for cancer treatment as the cancer treatment is not available in this country. We have top of the line cancer doctors in this country. But they have money, so their definition of care quality is very different. Now here is an investor who has invested 200 crore rupees into a business, and he is looking at the social aspect of it and he is also looking at the commercial aspect of it. For him to hire somebody who is a star doctor, possibly is a vehicle to launch his project, but as the time would have its own say, patients will come from the 60% pie, patients will come from this 10% pie, and you will have a whole lot of patients who will require a doctor who is not a star doctor. You know, once the regulation of stents came, the starting salary of a DM cardiology, at least in my state, has dropped from 5 lakh rupees to 3 lakh rupees. Alright, so that is what regulation would possibly do and make it available. If you ask today, a cardiologist, are you ready to go to hinterland and we are going to put a cath lab and you are going to do 200 procedures all by yourself because you will be the only cardiologist in that region. Patients will come from Ma Yojana, Ayushman Bharat and those type of patients. Trust me, you'll be more than happy to go. We have seen that, we are doing that in our hospitals. People are going to hinterland, unserviced areas. We have a hospital in a rural area. We are the only corporate hospital in the rural area. We do radiation oncology, we do cath lab, we do cancer surgeries, we do all types of surgeries. Trust me, there is a neurosurgeon, there is a neurologist, and all at a very, very reasonable cost. Because in the city, the competition is also increasing. So affordability, what Ayushman Bharat has done, the market dynamics for compensation would change tremendously, right? Just before we went into election, we had cap on medical oncology drugs. We are still to see the repercussion of that coming into the financials of the hospitals, right? Because that is what was possibly the thing for next decade. I always say that you go back to 2000 for corporate hospitals, cardiology and critical care was the thing. It was the queen specialty. And then in 2010-11, it became onco the thing. From an investor's perspective, we sitting with the investors. From an investor's perspective, that was the thing. So to sort of get return on your investment, initially possibly you may have to look at a star doctor. You have to use that as launch vehicle to launch your organization. As you rightly said, markets like Bombay, Delhi, Bangalore, Chennai, Hyderabad, highly competitive markets. And the number of beds, the number of doctors, number of super specialty doctors, but in those cities is humongous. It's humongous. And you're trying to put a project there, you better be ready for the tough time if you don't hire a star doctor.
That's an interesting thought, Ankush, and it's certainly music to an investor's ears. What you were suggesting is that a successful model can be created around a regulated pricing regime. If I take Ayushman Bharat, so you're suggesting that physicians are ready to realign their expectations to cater to the market needs.
I have a reason to believe so, because the current government, the outgoing government has done enough to improve the number of medical seats in this country. I was traveling to a very remote village called Mansa. It's around 20 kilometers away from Gandhinagar. Mansa has got a small district hospital, and to my surprise, they had DNB inspections, and they were to get 2 DNB seats in pathology. So government is not only looking at seats coming from MCR regulated colleges, they are also fueling the growth through DNB programs. The DNB board has been told that you look at more and more organizations to give DNB seats to create more doctors. They are trying to leverage CPS. So the number of inflow, Gujarat, if you look at it, trust me, we have 5,000 MBBS seats in Gujarat. As per Gujarat government, all 30 districts will have a medical college. right? If that type of influx is coming, it's a backward integration from a human resource perspective, because here you are saying that I'm going to regulate the market. You know that if you regulate the market, you will not be able to get the physicians who will work in regulated markets. You will not get investors to put money into a regulated market until the cost structure is taken care of, because ultimately investors will look at profitability. And from where the profitability will come, if you look at balance sheet of a company, HR cost, if you take the doctor component of it, is possibly the largest cost on the balance sheet, followed by the material cost. Right? So material will have its own limitations. Unless you try to sort of control the doctor cost, you will not be able to look at the profitability piece. And if the surplus increases, I am sure that there will be more and more people who will be available in the market 5 years down the line who will really work in those type of regulated markets.
So now, since we would have some healthcare operators in the audience, what would you recommend as an engagement, clinician engagement plan for somebody who wants to start out a hospital in this day and age? And it should be for both, for a saturated market like West and South, and for a market like East and North, because both these markets operate differently. While you mentioned that there are 5,000 seats in Gujarat, some of us would be surprised to know that there hasn't been any new medical college in the state of Bihar since the independence. So what would you suggest to operators for both kinds of market?
So if you go to Bihar and you don't have doctors, ultimately it is the market dynamics is going to play a role in designing what compensation model you want to have. Ultimately, any price is a function of demand and supply. So if you go to a market which is not so matured in terms of creating a human resource base, you're trying to put up a hospital there, obviously you also need to look at that how many corporate hospitals are there in Bihar. People who are 5%, 6% out of the pocket patients, do they really have good quality private healthcare in Bihar? So if you set up a project there with good quality infrastructure and good quality doctors, obviously the influx would be much more, because that is highly underserved market. It's not that competitive. But if you go to Bombay and Delhi, if you look at Bombay, or if you look at Delhi, if you ask CEOs of hospitals in Bombay and Delhi, Bangalore, Hyderabad, they would outright say that I'm not looking at Ayushman Bharat, because occupancies are buzzing, revenues are buzzing, you are able to command the price, city is willing to pay. Go to Bangalore, IT hub, most of them are covered by their companies. Right? They are really not bothered as to what is the cost that the hospital is charging, because it is their employer who is going to pay for that treatment. Right? So if you set up a hospital there, you will set up a hospital which is technologically very, very advanced, because the people there understand what technology is all about. But if you go to Bihar, if you set up a very high-tech hospital there, people will not understand what technology is all about. Right? Somebody is talking to us in the morning about mobile applications and things like that. So you look at the success that Practo had in Hyderabad, they had in Chennai, but did they had same success in Bihar? There are a lot of dimensions in bringing that model of compensation into play. It's the quality of patients, the quality of treatment, quality of service that you are going to provide in your setup. And at the end of it, obviously businesses are run for profitability. I'm pretty sure that there will be stress on the current service providers when these regulations would come, and they are already experiencing, and there is a lot of discussion as to whether this price point is right, wrong, revision, non-revision, and so on and so forth. But trust me, 5 years down the line, whether it is Bihar or whether it is Bangalore or Hyderabad or Chennai, this will be a third-party payer game. The question is, who is going to be the third party? Whether it will be government or whether it will be a private insurance company. Most of us are looking at deep penetration of insurance which has started taking place in our country. Every educated individual today understands that what health insurance is all about. So it is not that situation where we were 5 years back and there was the penetration was not there. So government also incentivized you buy insurance and you get tax benefits and so on and so forth. The only complication and the only challenge that I see is that when you go to fixed pay models, right, then obviously, what are you saying? You are saying it will become assembly line. If I have to look at it from an engineering perspective, you are saying that it will become an assembly line and there will be 20 odd patients will pass through a cath lab in a day. Right? And that is where you will have to keep those people engaged, that yes, fixed pay is there. So he will say that whether I do 5 procedures, I do 15 procedures, my per day comp is same. And that is where you will have to possibly motivate him that if you do more, I know the exit profitability, I would be able to share some part of the profitability with you, but you have to put quality care, again that's subject of discussions of debate, good quality care and reasonable throughput through the system. Ultimately it's not money and you will be able to incentivize.
Thanks for that thought. So I guess I've just been told to wrap it up. So maybe I can take the next 5 minutes and open it up to the audience if you have any questions for the panelists. Yeah. Joy.
This question can be both of you, one of you can answer. You mentioned about the fixed salary for the consultant, for the doctor in your organization. So question is, when you recruit, let us say for any particular specialty, a doctor, post-qualification, 10 years of experience, do you fix their salary in the same level?
Salary at the same level may not be possible because they have different level of competence.
No, what I mean is, when you say competence means with the same number of years of experience, you mean someone is doing much better, someone is not doing that great. Is it your competency?
Correct. So the thing is that some volume-based incentive doesn't exist. It's a complete group practice. So everybody has to develop to that level, and that is where we come in. If the person is not performing, if it's not skilled enough, it's not generating that volume, help and support is given. So basically, all would have almost similar kind of a caliber over the time, but we give time. Another important thing which I missed is if I have 12 cardiologists, all of them don't do angioplasty. Everybody has to bring in a skill set. So somebody will get into preventive, one person has to get into diagnostic, advanced diagnostic, and electrophysiology and 3D mapping. And during that time, they may not have volume, and so that we allow them 1, 2, 3 years. But to answer to your question, there is no volume-based incentive, and it is a group practice. And but definitely there would be, if lab polycystectomy is done by general surgeon and also by GI, at times it happens because there is always a thin border between it belongs to whom. It would definitely be a differential priced and differential paid.
But if the two specialists from the same specialty, the volume is same, but someone's outcome is better in comparison to the other person, do you give any additional financial incentive?
No, so there is no financial incentive, but he is always told, because there is a utilization review. There is a separate department to answer that question regarding Ayushman, can we survive that? There is a utilization review team which monitors, we have ECHS, we have CGHS, we have ESI. So which monitors appropriate stay, appropriate pharmacy, appropriate diagnostics, appropriate treatment. And this has been monitored not by clinician, it has been monitored by a nurse. And a nurse and a clinical pharmacist are empowered to tell a cardiologist also that it is not appropriate and they need to come down because that is not good care. So that empowerment helps us to keep our costs down, and they would be at the same level of pay, and if their volumes are same and their competency are same. If not, then we speak to them and show, because our management review meeting would not be financial at all. It is all on quality parameters and their outcomes.
See, if somebody's outcome is better than the other person, what is the harm in giving them better financial incentive?
There is no harm. You pick The clinician picks Amrita Institute picks clinician, absolutely no harm. The choice is theirs, choice is ours.
I think the answer is basically you can have differential payout as long as it's transparent, the physician knows, and it's not only volume driven. There are matrices that you have to make that, to create that differential.
Are we having any more questions? We'll wrap it up in 5 minutes. Okay, so.
Regarding the incentive thing, why can't we have an incentive quotient kind of, just like intelligence quotient? There should be an aptitude test for all post-PG students regarding the incentive quotient. Means whether they prefer more financial incentive quotient, they prefer more social quotient, like they want to work in charitable. Some doctors are like, we don't want much more financial things. So they can go into some charitable things, or some can go into the academic thing. So that should be a major of, like a kind of a personality test for doctors, what they want.
If you look at the advanced HR practices, so they are not right now applied to clinician hiring, but there are a lot of psychometric tools which are available on the HR space that can be applied to hiring of clinicians and physicians. As of now, world over, people have tried applying psychometric tools to the recruitment process, but at least I am not aware of any success models.
Sorry sir, I would like to interrupt. Our next speaker has to leave in another hour, so we'll wrap it up here.
I just have one quick question. I don't know if the hospital...
Can we take that in the lunch break?
Just give me half a minute. Okay, maybe it's a question which they can discuss later. Is that I don't know if the hospitals have started practicing something called the freemium model. That means the OPD, for example, is free. They don't take anything from the patient, but with the intention that the patient would come into the IV. In such cases, how do you incentivize the entire thing? I would like to know more about it.
So maybe we can take it up offline, but quickly, two things that have certainly come out is that you can have a non-volume driven incentive model, something that Dr. Sanjeev spoke about, and then very encouraging to hear Ankush say that clinicians are aligned to the new payer model that we are witnessing in this country. So with that, thank you everyone.